So may I invite Dr. Meer Chisthi next?
Good afternoon, everyone. At the outset, let me place on record my gratitude to the organizers for having given me the opportunity to discuss this very important practical topic in front of this august audience. So, what are we discussing? Is it focused abdominal sonography for trauma, or is it focused assessment by sonography in trauma? Let's hope to have the answer at the end of this presentation. In fact, if you look at the history of FAST, it was as early as the 1970s when the Japanese and the German sonologists basically wanted to create a concise protocol for assessing trauma patients. Later, the idea got caught up, as always, in the United States of America, and it was exactly in 1995 that the first report of a formal 4-window assessment for FAST was published. Subsequently, in the next year, the name, that is the acronym FAST, was given by a publication by Shackford. So what exactly is the basis for FAST? For a human patient in the supine position, there are definite areas in the peritoneal cavity where fluid, in fact any fluid, will track down. These include the right side, the hepatorenal pouch; on the left side, the splenorenal pouch, the bilateral paracolic gutters, the pelvic cul-de-sac, and a few more sites. So the basis of FAST is that you are using your ultrasound machine to have a look at these specific sites where you can pick up the presence of fluid. And obviously in trauma, that fluid is nothing but blood. So basically you want a convex transducer which will look at these sites for presence of fluid, and unclotted blood, because it is anechoic, will appear as black, whereas clotted blood starts to appear from gray to sometimes even white, and the whole procedure takes to any time between 3 to 5 minutes. The classical 4 windows are the right upper quadrant, then the subxiphoid or the cardiac window, the left upper quadrant, and the pelvic or the suprapubic window. And in all these positions, the probe is placed in such a way that it is facing the patient's head or the right side of the abdomen. You start off with the classical position, that is the right upper quadrant, and here you are looking for the presence of fluid in 4 sites, that is the subphrenic space, the pleural space, the Morrison's or the hepatorenal space, and the paracolic gutter. This is how a normal FAST will appear. I hope that is clear. You can see the liver on this side, and here is the kidney. There is nothing in between. This is normal tissues. So this is safe and negative. Whereas if you look at this picture, there is blackish, that is fresh blood between the liver and the kidney. So this is nothing but right upper quadrant FAST positive. Few more pictures, same condition. There is presence of free fluid in the Morrison's pouch. So having moved from the right side, you now go to the left side. Here, very often it is missed because the spleen and the recess are much more caudal and much more posterior than we presume them to be. That is the usual reason for missing the findings here. Here again you can see the normal spleen, normal kidney, nothing in between. Whereas here it is very well made out. You can see the presence of the blackish free fluid between the spleen and the kidney. Again, 2 classical pictures showing the free fluid moving in the splenorenal recess. So now you move your probe just below the xiphoid process, place it directed towards the right shoulder, and the probe almost parallel to the skin surface. Here the idea is to look and pick up a pericardial tamponade. If this view is not diagnostic enough, you can go for a parasternal view also. The normal subxiphoid view, where this is the liver and you are looking at the interface between the liver and the heart. You can see the both ventricles and atria with no fluid surrounding the cardiac chambers. This is definitely fluid positive. You can see the blackish fluid surrounding the heart. Again, on this side also, you can see there is moderate amount of pericardial tamponade. Along with your cardiac assessment, you can also know the patient's fluid status by looking at the inferior vena cava. You just need to rotate your probe by 90 degrees, and any diameter of the inferior vena cava less than 2 centimeter at a distance of 3 centimeter from its exit from the right atrium. That indicates insufficient volume. And any value less than 1 centimeter means it is definitely hypovolemia. More than 2, you are happy your patient is either euvolemic or might even be hypovolemic. Another point you are looking at for is the collapse of the inferior vena cava. Normally the IVC collapses during inspiration. If it is exaggerated, that also means that the patient is hypovolemic. So these two pictures show a normovolemic patient. This is a definitely hypovolemic patient. Lastly, you put your probe at the pelvis. Here you have two views, both the transverse and the sagittal views. This is a normal pelvis, the transverse view, where you can just see the anechoic view given by the bladder. The same thing in the sagittal view. So any fluid which is seen behind the bladder or on the sides indicates pelvic vas positivity. So you can, in this picture, you can see the free fluid just behind the bladder. In females, you might often see the fluid behind the uterus, that is in the rectovesical fold, whereas in males it is seen behind the bladder itself. So again, a beautiful image showing the free fluid just behind the uterus in the female, and here it is seen behind the bladder. And once having finished your abdomen assessment, you are now going to look at the chest also. For this, preferably a linear probe is used, and you are going to look for presence or absence of pneumo or hemothorax. Pneumothorax is basically diagnosed by absence of normally present lung signs. In normal lung, you will see some definite signs which include the lung sliding sign, the comet tail artifact, the seashore appearance, and the A-lines. Absence of these means you should suspect a pneumothorax. Also, you will have pathologic signs which includes the barcode or the stratosphere sign and the lung point. Hemothorax, you get one specific sign, that is the spine sign. So if you can make out on the left side, this is the positive lung slide, which is seen when there is no pneumothorax. A normal patient, this is sometimes called as the line of ants moving. This is the lung slide sign. This means this patient has no pneumothorax. Whereas on this side, the lung sliding is absent, which means the patient has a pneumothorax. Again, this is the normal seashore appearance you see in a normal lung, and this is the barcode. This is very well, looks like the barcode of a pneumothorax. And lastly, the spine sign seen in a hemothorax, where you can appreciate the spine very well. So how accurate is a fast? It is told that any fluid more than 200 cc will be picked up by fast, and the sensitivity ranges somewhere between 75 to 85%. Specificity is more than 95%. So what does that mean? See, after your fast, if your sonologist is telling you that this patient is fast positive, then you should believe your sonologist. Take it as fast positive. Whereas if the sonologist is telling you that this is fast negative, then take it with a pinch of salt. You have to use your sense, follow the patient's hemodynamics instead of blindly following the fast report. And it is better than chest X-ray for demonstrating pneumothorax. So what are the advantages? You can do this as much as you want. It is a rapid, non-invasive, no radiation, no toxins, nothing. And it can even be done very well by ER physicians. This study came up from our own All India Institute of Medical Sciences. It is 100% efficient in the hands of ER physicians. The cons, the disadvantages, there are a large number of false positives due to thickened pericardial fat, cyst, even a thickened perinephric fascia, ascites, even a physiologic rupture of ovarian cyst can bring up a false positive. Whereas false negative can occur due to obesity, presence of air inside or outside the chest wall, inadequate volume, too much or too little time since the trauma, and even encapsulated bleeds. So to summarize, it is focused assessment by sonography in trauma because you are assessing both the chest and the abdomen. Always try to get an E-fast because you can assess the chest also. And always follow the patient's vitals more than your fast report. Repeat as often as you need to. Thank you.
Excellent presentation. Very nice
sir.
that you have shown the videos also. Thank you.
Thank you, sir.
A common terminology is that we come across that we have already discussed, fast, E-fast, and another one more is WBCT, full body CT. So can you give the indications for these three?
Yeah. Actually, now the recommendation as per the 10th version of the ATLS is to go for EFAST for all patients with trauma. Whole body CT has got specific indications. That is, it is told that any patient who has got a major trauma, means the patient has sustained a significant road traffic accident. Those patients, it is better to go for a whole body CT. Whole body CT means we have to start from the head and go till the upper thigh. That is specifically done in patients who have a major trauma, whereas EFAST is recommended in all trauma patients. I hope that answers.
Any question from the floor?
One more disadvantage is that the retroperitoneum and the preperitoneum is also not better assessed by the EFAST.
Definitely, yes. Thank you for pointing that out.
No more question. We will conclude. Congratulate all the speakers.
Thank you.
Thank you, sir. Thank you to all the esteemed chairpersons of the session.